Great. All right, so our conversation is about blinding, matching, and randomization. So when I was thinking about how do I put this together, what is the common thread across these three concepts? And because I quickly realized and remember that there are actually statistical methods for improving the validity and reliability of research. So if you're thinking about blinding, matching, and randomization, and you're asking why did they put these three topics together, what joins them, the common thread across these three topics, is that we are discussing statistical methods for improving validity and reliability of research. Now, blinding, matching, and randomization aren't the only three statistical methods for improving validity and reliability. So for extra measure, I thought to throw in some of the other statistical methods, and we will see that as we go along. And hopefully in the next 40 minutes or so, we should be able to have quite an interesting and an engaging time. We would aim to facilitate understanding on the need for research validity and reliability when we're designing and crafting objectives and designing our research methods. Why do we need to pay attention to validity and reliability of research? And then we will look into the nitty-gritty details of blinding, matching, and randomization, and how these help the processes, the procedures for these statistical methods, and how they help us achieve validity and reliability for our research. And then, of course, we'll look a bit about the pros and the cons, the advantages, disadvantages in the use of these methods. And like I said, I'll be adding other methods into the mix. So this is how the presentation, the talk will go. We will look at what research is. We will link it up to the validity and reliability of in research, and then we'll do some explanations about randomization, matching, blinding, and other statistical methods for determining or achieving validity and reliability. Of course, I mean, I have to start at the very beginning just for a few slides to kind of paint the picture and give the background that research is the systematic collection, analysis, interpretation of data to answer a certain question or to solve a problem. I believe in simplicity, that even very complex concepts can be made very simple and easy to understand. So if you think about it, everything we are doing must follow a systematic process. Research is both a science and the art, but you cannot lay hold of the art and forget the science, and you cannot throw away the science and you cannot go after the science and forget the art. So there is a need to systematically collect, analyze, and interpret available data, or data you would go search for and get, or data you would put in place by one research method or the other to answer a question or to solve a problem. And so, in line with that, research by nature needs to have very clear statements of the problem. So before you can answer questions about a problem, and before you can find solutions or implement solutions to a problem, you need to have clarity about what the problem is. What is this problem, and why is it interesting enough for us to get involved in solving it? And in order to take it from a problem and take it to the answer or to a solution, you need a roadmap, and that roadmap is your objectives. And objectives, of course, need to be specific, measurable, achievable, realistic, and time-bound. SMART objectives. Clear objectives that can be followed, that tie into methods, that tie into study designs and tools, and that tie into results and tie into discussion. So I usually like to say that when it comes to research, virtually everything rises and falls on the quality of your objectives. Another characteristic of research is that it is systematic, so it requires a plan. It's not the aimless looking out for something in the hope that you will just stumble on something. No, there is a method and there is a plan to research. And of course, research is not, we stand on the shoulder of the giants that have gone ahead of us. So research always tries to build on existing data, always tries to build on existing research, and tries to further our understanding and our knowledge and push the frontiers a little bit more than where we currently are, while remembering what we have seen or what people have done in the past. And of course, it is amenable to a systematic collection of data and an analysis to respond to the research objectives. And so quality research, like I said, objectives will be SMART. We will also recognize quality research when the conclusions are true to reality, based on accurate measurements. And this is what we call validity. A study is valid when it actually, when the results, when the conclusion is actually depicting the truth of the situation. And that is only because measurements were accurate. So this study was able to, there is a difference, there is an association, there is a relationship, or there is none, and this study adequately and accurately identified that. And then, of course, repeatability is also another quality for research. When I can take your research methods and your objectives, I can study what you did, and I can do it. Take your methods, take your tools, take your study design, take your objectives, and I can replicate it in a similar environment, and I can actually find similar results. And if there are differences, there's a clear-cut understanding or reason that I can identify why my findings will be different from your findings. Not that your study design and your findings were quite ambiguous and difficult to follow. Then there is generalizability. That's another quality of good research. Generalizability refers to the fact that you are able to, one is able to apply the findings of this particular research, which was done in a sample, apply those findings to a population. So the way the sample was recruited, the way the sample was found, the way the sample was included is actually representative of the population. Therefore, whatever findings, whatever results that come out of that research endeavor, it is easy to apply it to the general population. And finally, like we have said before, if these things are in place, research that will be of quality will provide answers to questions or will solve problems. Now I'm going to take us through like a short revision on study designs. I know we are quite aware of this, but the reason I'm doing this is that it's going to lead into the issues of validity and the statistical tools and methods for establishing validity, and then of course lead into randomization, blinding and matching. And so, but I just, for us to understand this schema, apologies if it is tinier than what you can bear to read, but I will just give it some explanation. So all research is in two broad categories. So you are asking yourself, did the investigator assign the exposure? Was it the investigator that assigned an exposure? If the answer is no, all the investigator is doing is observing phenomenon as they occur, then it's an observational study. If the investigator is actually the one creating some manipulation, is the one causing an intervention in one group and not giving it to another group, or is the one that has something that he wants to try out, a drug, a procedure, a surgical procedure, whatever manipulation, whatever intervention, whatever experiment that the investigator wants to carry out, if it's something the investigator and team are actively going to do and measure the effect of, then you have an experimental study design. When we go into observational, I will quickly talk about that and try to dismiss that in the next few minutes so that we can make progress. When you go into an observational study, you ask yourself the next question: was a comparison group used? Any comparison going on here? If the answer is no, then you have a descriptive study. If the answer is yes, there is some level of comparison or the other, then you have an analytical study design. And when you go into a descriptive study, you ask yourself, what direction was taken? Is the direction taken just to report what has already happened? So if it is a report for things that have already happened, outcomes have already occurred, and all you are doing is reporting it, then you have a case report. for one individual, a case series for a group of individuals that have the same outcome, like people that have the same disease. So you want, if you want to study the characteristics of people that have a particular maybe mandibular fracture, or who have caries, they all have caries. They all have that outcome. And then studying them from looking at case notes and files and folders and stuff like that is actually a case series. And of course, if you want to go into more details on that, it's a case study, trying to ask yourself, why did they come up with what they came up with? But basically, we're reporting information that already exists about an outcome that has already occurred. So that is case report, case series, and case study. The other part of it is that you're actually taking measurements. So risk factors and outcomes of interest are happening at the same time. A snapshot of the population at that time that you are taking the information from the population, risk factors, exposures, or outcomes of interest are happening at the same time. What you have is a cross-sectional study that is descriptive. So you have a descriptive cross-sectional study because you're actually taking measurements, and the tools that you are using are trying to find out risk factors, outcomes, and measure those risk factors and outcomes happening at a particular point in time in the population. Flip over to analytical design. You ask yourself, for analytical design, there's a comparison, but you ask yourself, at what was the starting point for the research? And I think this is important to always remember this helps us quickly remember the difference between a cohort and a case control study. Because in a cohort study, the starting point is that there's an exposure. So the groups, 2 or more groups, are identified based on the presence or absence of the risk factor, otherwise called presence or absence of the exposure. And then you are following them to identify outcomes that you have said you are interested in. Then if it's a case control, the outcome has already occurred. So the 2 or more groups are based on, you are recruiting people into 2 or more groups based on the occurrence or the lack of occurrence of an outcome of interest. And you are searching back in time to identify exposures or risk factors. But when exposures and risk factors are occurring at the same time in 2 or more groups, what you have is an analytical cross-sectional study, otherwise called a comparative cross-sectional study. And then the one that we're going to dwell on a little bit more, because it relates directly to validity and reliability and to randomization, blinding, and matching, is the experimental design. Remember, the experimental design is because the investigator is creating some manipulations. So the question to ask in the experimental study is, was the allocation randomized? And we will go into details about what this means. If the allocation to intervention or control group was randomized, it was left to probability, it was left to chance, a probability method was used, and it wasn't by the decision of the investigator, neither was it by the decision or desire of the study participants, but it was only probability methods that decided whether they would get into the intervention or the control group. You have yourself a randomized control trial. If that was not in place, it is a non-randomized control trial. And there are various variants of this, and we'll go on to look at that. So let's dive into an experimental design, because we'll find that it's very relevant to the conversation that we are here to have today. So this is what an experimental design, the process of an experimental design looks like. So you will have a study population, and you will take a sample from it. You calculate your sample sizes, and then you take a sample from it. And then you would now, from the sample population, you will do a sampling from the study population rather. You will do a sampling to pick the number of people that you have decided from your sample size estimation to bring them into the study. Remember, before you do that sampling, you would have identified those who are eligible using your inclusion and exclusion criteria. So study population, eligibility criteria would have been applied, and then you now do your sampling. Hopefully you would use a probability sampling method to bring people into that study. So once you have your sample population, the number of persons you have in your sample population, you will need to use randomization to, this is a true experimental study design now, a randomized control trial. You will need to use randomization techniques to allocate people, study participants or study subjects, to the experimental or interventional group, to the control or comparison group. You will need to use you will need to use a randomization technique. So if you do, when you do that, what happens is that your intervention group, experimental group, and your control group, they will both have measurements at baseline. They will both have data collected at baseline before the intervention is introduced. There will be a period of intervention for one group and a period of no intervention for the other group. Even though in the other group, you may give a placebo that mimics the fact that there makes the feeling that there's an intervention, therefore blinding the participants. We'll talk about blinding a little bit more to whether they are getting the intervention or active intervention or not. But there is really, in truth, no intervention at this time. And then after okay, apologies. I think I lost internet connection for a few seconds. Prof. Barmo, can you make me a co-host so that I can share screen?
Okay.
Thank you, sir. All right, thank you very much. Okay, so let's see if we can pick up from where we were interrupted. Apologies. But please confirm that you could all hear me very clear so far before I tripped off.
Yes, I'm hearing you right now.
Okay, thank you, sir. Okay, so my slides are coming up. Okay. All right, so this is where we were. And just to wrap that up, is to say after the intervention, you will take another set of measurements and you will compare the measurements between the experimental and the control group. And that's what the flow is. So let's talk a little bit about validity and reliability in research. I've given you the explanations or the definitions of validity and reliability. So just to repeat, is a piece of research is valid, is said to be valid if the findings, the results are actually measuring, are representing what is the truth of the situation. So if you studied a sample versus the study being actually done in the population and done properly, your results, would they look like the results for the population study? How valid are your results? How close are your results and your findings to the true situation of things? Reliability talks about if I repeat it, if I do your study a couple of times using your methods, am I able to get similar findings or similar results? So this graph here shows us, it's kind of like a bull's eye. And if you throw darts, or if you know anything about throwing darts, you would remember that the focus is on getting to the bull's eye. This red dot right in the middle. So research needs to get to the bullseye. It needs to identify the real situation of things and measure in truth, which means that your measurements must be accurate. Your recruitment methods must also be valid and accurate, and you must accurately your results must approximate very, very closely what is the truth of the situation. And so you have the interplay of validity and reliability in research, and you want the two to really come together as you can see in this last picture. So you see that several research was done about using the same methods, using the same maybe samples taken from that population, using virtually the same methods and the same design and structure. And you find out that every time there was bullseye or close to bullseye, as close to as possible is what we're looking at, you know. So we in statistics, we'll hardly say there's 100% confidence, but we're happy with 95% confidence, as close to it as we think is humanly possible. So in the last picture, you will see that you have dots, which are your findings for your research in the bullseye. You will also see that all the dots are close to or in the bullseye, which means that repeating this multiple times by collecting various samples of that same population and studying it gives you results that are reproducible. The results are virtually the same. That means that your research is reliable. And then, of course, you can see in the third one where my cursor is, the one at the bottom to the left-hand side of the one we are aiming for, you see that it's reliable. So you still keep getting the same or similar results, but it is not valid. They are all wrong. They are all wrong. They are not, none of them are approximating the bullseye. So something is wrong here, and we don't want this scenario. If you look at the one directly above it, you see that they are both unreliable and invalid. So no one is hitting the bullseye. None of the studies are approximating what is the truth or the reality of that situation in the population. And at the same time, you're getting results from different studies that are all over the place, some on this, some negative, some positives, everywhere. So in this one, which is actually the second one on at the top, you will see that you have at least one of those samples taken from the population gives you the correct results, So you can say it is valid. Assuming this was the study you did, you say it's valid. But when other people try to do the same thing from population that you have used, they get all manner of results. That means you haven't described your method sufficiently enough, or there were errors in what you put down that we couldn't follow, and therefore we were not getting reliable. Your tool is not reliable, or the design or the collection methods you put together is not, even the analysis method too can. So what are the threats to validity and reliability? These threats are caused by three major things. It is not exhaustive, but these are the three major things. The first one is confounding, the second one is bias, and the third one is attrition. I'm using the word attrition here specifically because we'll be looking at analytical designs and experimental designs. For the conversations we're going to have going forward, we're no longer interested in descriptive designs. The other descriptive cross-sectional or case series, case reports, we're no longer focusing on that. We're now focusing on analytical designs and experimental designs because the conversation about confounding bias and about how to control for that with randomization, blinding, and matching all have to do with, at the very minimum, an analytical design, a case control, a cohort, and then way up to a randomized control trial. So the reference going forward would be to either a randomized control trial, quasi-experimental design, or an analytical design at the very minimum. So let's look at what confounding bias is. We'll zoom in on these two and talk about it. So I'll pick that up a bit later, confounding and bias. But if you think about it, when you talk about confounding, you are really referring to factors, variables, risk factors, exposures that have a relationship both with the outcome of interest and with other risk factors or exposures. So what you have basically is the outcome of interest is usually termed the dependent variable. Dependent because what you get in the outcome, the main outcome that you're interested in, pardon me, I'm trying to set up my slides again. All right, we've done that. Okay, so I was talking about confounding, and explaining that when you talk about a confounding variable, you are referring to a variable that is related to the dependent variable or the outcome variable, the outcome of interest in your study. For example, if your study is looking at the relationship between nighttime snacking, I'm just thinking of something off the top of my head, relationship between nighttime snacking and the development of dental caries. Obviously, your outcome variable is the development of dental caries, the prevalence of development of dental caries. That's your dependent variable. Nighttime snacking is your independent variable. So it's the one that you're trying to find out whether there's any relationship. What changes is your dependent variable, depending on whether the independent variable, which is nighttime snacking, whether it has any relationship or not. So typically, that is what an analytical study would look like. Not an intervention now, but probably maybe a case control or a cohort, depending on how you frame it and how you select your study participants into groups. Now, a confounding variable may actually be age. So for example, let us assume that people who are, of a certain age are more prone to nighttime snacking. Or let's use sex, actually. Let's say that females, for whatever reason, are more prone to nighttime snacking than males. Maybe it is pregnancy pica, maybe whatever it is. I'm just bringing examples off the top of my head. There is a relationship between female sex and nighttime snacking. And let's also assume for this example that there is also some connection between female sex and the development of dental caries. Maybe females are more prone, from our understanding of biology or hormonal, whatever, are more prone to dental caries than men. So you can imagine that you go and you want to do this study and you would have recruited people, let's assume it's a cohort. You would have recruited people in one group, you would have recruited nighttime snackers. And in the other group, you would have recruited non-nighttime snackers. And then you want to follow them up for 2, 3, 4, 5 years to see what dental caries they develop. But what you don't know is that you have more females, and you didn't think anything of it. More females in the group of nighttime snackers than you have in a group of non-nighttime snackers. You will see an association, for example, by the time you're done. You might even see that, oh, the relative risk, the women, people who are nighttime snackers are 5 times more likely to develop dental caries compared to those who are not nighttime snackers. But the question really is that the true relationship? A confounder will either increase or reduce the true relationship. So it will potentiate it or it will decimate it. So that's what a confounder does, because there is another relationship going on there between the confounding variable and the independent variable, as well as the confounding variable and the dependent variable. So it just blurs the picture. So it's very important that for validity and reliability, we're able to handle and deal with confounders. The other one is bias. Bias is a systematic deviation from the truth. And this has to do with how you recruit the study participants and how you measure. So the two major sources of bias in research, especially in analytical study designs, the two major causes of bias are selection bias and measurement bias. How did you decide who goes into which group? And how are you measuring? How you measure, what tools and all that are you using? Of course, and we know what loss to follow-up is. You started with a group of people, and then down the line, in a longitudinal design, a prospective design, some of them stop being involved in your study. What do you do about it? I'm going to really move very fast now because my time is ticking. Threats to validity and reliability, and I'll look at how they can be resolved. So sometimes a study design threatens with validity and reliability. When that happens, what do you do? An analytical or experimental design just improves that. A cross-sectional design is really difficult for descriptive cross-sectional is difficult for validity and reliability. There's no temporal relationship. You don't know when what started. Risk factors and outcomes of interest happen at about the same time. So you are not really sure what is going on with regards to relationships, associations, or effects. You can't tell. So your study design, if it's an analytical study design or an experimental study design, helps to improve the validity and reliability of your study. The other thing is your sample size. If you use the right formula, if the sample size is large enough and sufficiently powered, if there is a relationship or an association, you should find it. If there's an effect, you should find it. The other matter is sampling. A probability sampling method is much better for validity and reliability compared to a non-probability sampling method. The simple random sampling is actually the best. This is the reason why, if your sampling is not simple random throughout, if you're using multi-stage and you're going to have cluster, stratified, or systematic somewhere in between, you need to multiply your sample size by a design effect factor of 1.5 or 2 to be able to control for that. Moving on, participants allocation. This is where we are coming to. So participants allocation is something that can threaten it. If you do not allocate people to cases and controls, or you do not allocate people to intervention and control groups properly, you will have issues of measurement bias, you will have selection bias, and you will have issues of validity, because you are actually not going to be getting the true picture because of a lot of confounding variables that you haven't controlled for. And so randomization, matching, and blinding are useful to solve this problem. And of course, when it comes to data collection, you have issues with standardization of tools. And if your tools are not standard, if you developed it by yourself and it's not actually measuring what it's supposed to measure, your comeback alpha is all over the place. It's difficult for you to have a valid and a reliable study. So standardization of tools helps, even blinding for the data collection. So the people collecting data don't know whether they're collecting from intervention or control group. And during the data analysis period, you can also make grievous mistakes in data analysis that will impede validity and reliability. What do you do about it? Most times a regression modeling. All right. So these are the things that we're going to discuss down. I've discussed this, that an experimental, just to remind you, an experimental design has an intervention. So there's a manipulation, there's a control group, and then there's randomization. These are the three characteristics of a true experimental design. If you do not have randomization, it's called a non-randomized trial. If there are any other of the things missing, either there's no control group or there's no randomization, it is a quasi-experimental study. So a non-randomized controlled trial is an example or a type of a quasi-experimental study. You can have a study they call the before and after study. That is actually a quasi-experimental. In fact, some schools of thought to say it's a pre-experimental study because it doesn't have randomization, it doesn't have control, or even worried whether it's even actually an experimental design itself. So this is what it looks like. Let's go. Okay, so control and comparison group. So when we talk about randomization, you need to understand control and comparison group and how it's selected based on the presence of the exposure, if it's a cohort, the disease, if it's a case control or intervention, if it is an experimental design. And what you're aiming for validity and reliability is that the controls and the cases, or the controls and the intervention group, should be similar. The people in these two groups should be similar in almost every other thing apart from the factor that you are viewing, the exposure or the intervention effect. How do we do randomization? So after you've done your eligibility and you've done your sampling, and you have this pool that you are ready to bring into intervention or control groups, this is where randomization comes in. So probability determines who gets recruited into the intervention or the control arm, not the researcher, not the participant, not a data collection staff, not the person analyzing. Nobody influences. So if you say something like this, a dental technique, a dental procedure that you want to test to see what is the effect of that dental procedure or on patients, and you say, look, everybody who comes to the health facility, as they come into the facility, we would recruit them if they meet the eligibility criteria. We will recruit them into the study. You are the study, you are the data collection officer, you are the research assistant. As they come, the first person goes into intervention. It goes into intervention. The second person goes to control. That person goes in. So you use like a systematic method. Intervention, control, intervention, control. You'll probably be clapping hands for yourself that you're doing a good job, but that is not randomization, because there is now a predictable pattern about who gets into an intervention and control. Besides, the research assistant knows this is intervention, this is control. What is to stop him or her from wanting to put his friend or family member in intervention and then move an enemy or somebody that hasn't been greeting him or her very well into the control? So you have to be really careful about this. So the best way to do this, now there are apps, there are applications that you have online. So if your study size, sample size is 300 and you need equal distribution into intervention or control, you have your study code 001 to 300, and then you now say, I want two groups randomized. So you have randomization apps. You can even go on Google right now and download them. They're all there. You can use them on the internet directly. And it will tell you serial numbers 5, 20, 16, 14, like that. In a very, probability decides in a random manner. They'll tell you the 150 that are in this group and the 150 that are in the other group. And all you need to do, as someone comes in, you have a bag that has these codes inside the bag, or an envelope that has these codes inside. The person picks 5. You see 5 and you go and look at your records. 5 is group 1. You say, okay, thank you, welcome, sir. You are in group 1. So when we look at blinding later, you see that you are not even supposed to know which group is intervention, whether group 1 is intervention or group 1 is control. You just know there's group 1, there's group 2. The participant doesn't know either, so but we'll talk about that in a while. So that is randomization. It is probability that decides who goes in. And what the beautiful thing about randomization is that you have an equal distribution of known or unknown confounders. You will see that the other statistical methods actually address known confounders like matching and blinding. You know what you are trying to prevent. But with randomization, you know that it is possible that you don't have it all. You don't have the full picture. There may be a confounding variable that you are not aware of. We know that age and sex are the two most notorious confounding variables, and all the other so-called background variables, education, social status, occupation, they are known confounders. But there are some confounders that you may not know because you don't have any experience with that before. So what are the types of randomization? You can have a simple randomization. With a simple randomization, you are assigning individuals. So that's, and I'll correct that before saying in the slides. Assigning individuals to treatment or control groups based on probability. So in simple randomization, individuals is the focus. In stratified randomization, you are not just randomizing individuals, you are looking for certain known potential confounders, usually with the background information. For example, age, sex stratification. So as you're doing that, you have a sub randomization for males, females, because you want an equal number of males compared to the other group. The two groups, you want them to have equal number of males and equal number of females. Or in the two groups, you want equal age distribution. So you do a stratified inside your randomization. And then there's what you call block or cluster randomization. So you have a group of people. So you say, okay, people coming from this community, you are randomizing them, while those coming from another community, so you are randomizing them to one group, while those coming from another community, you are randomizing them to another group. You can say clinic days. Everyone who comes into this clinic and is eligible for this clinic day, Monday clinic is being randomized into this group, while anybody who comes on Tuesday clinic is being randomized into the other group. So that's block randomization. And then with adaptive randomization, you probably will start out with one randomization method or type, and then you will see as results come out, as data emerges and all treatment changes, you want to switch it up and you want to make some adjustments in your randomization. So that's adaptive. What are the challenges with randomization? It's really often not always practical, feasible, or possible to do randomization. It's not always feasible, it's not always practical, it's not always possible. There are some situations where randomization is clear impossible to do. I'll give a couple of examples. So for instance, you are intervening, your intervention is on a particular community. So you have a grant, and what they want you to do, grant is targeted to a particular community. So the funds are for that. And you want to do implementation research as you are implementing that grant. So obviously, everybody in that community must receive your intervention. And then you now want to go to a community, a comparison community that is not going to receive your intervention, and then you want to compare. That is a quasi-experimental design, and it is valid. A quasi-experimental design is valid, and there are many reasons why you may not be able to do a randomized control trial all the time. And so sometimes you just do a quasi-experimental and you shelve randomization. But there are other things you can do to improve validity, even though you are not randomized. We'll talk about them down the line. And so other thing is ethical considerations. I can remember a conversation I had with a colleague a couple of weeks back, almost maybe about 6 weeks ago now. And he had this, so he's a neurosurgeon, and he had this procedure that measures an EEG during seizures or something like that. It's a new technology, not really new, but we haven't used it in Nigeria. And he has a few of those kits, maybe like he got 50 of those kits. It's a one-off use kit. So when somebody's having a seizure, it measures something and it helps to intervene and manage the situation. I don't recall all the details. And he wants to test the usefulness. It's never been tested in our environment. A few people have said, yes, it works. Some other people have said it doesn't work. And ambivalence is one of the reasons why you want to test out an intervention. So he wants to find out whether it works. Now, the question I asked him is, who are you going to? How do you decide who gets? Because what it will mean is that a group of people will have this machine while they are in seizure. Then another group of people, you see them, they are in seizure, you will not give them the machine. How do you want to get away with that ethically? So I took him to task to ask, how are you going to manage the ethics of it? And then, of course, some of the things came up. I have only a few of this. Will I not use it? I will use it on the first set of people that come. Then the next set of people, once it finishes, it finishes. I don't have more. Then the next set of people that come, I don't have. If I had, I would have used, but I don't have. So I'll measure them like that, and I will use that. So that's something like a quasi-experimental kind of design. But you're seeing what I'm talking about with ethical considerations. So if you're not able to do randomization, and sometimes even when you're able to do randomization, you can still do matching. So matching is useful for the analytical designs. It's also useful for the experimental designs. What happens in matching is that individual matching, if you identify the variables you want to match for, usually they will be background variables, or sometimes there will be some other variables of interest that you want out of the way. You do not want them messing up the picture of what you're actually saying. So individuals in one group are selected based on the presence of the known variables. So you select, for example, assuming the variable of interest is sex that you want to match by. If you select a male into the one group, you must select a male into the other group. You select a female into one group, you must select it. So to the exclusion of everybody else, if you're going to do randomization, you will exclude all the males from that randomization cycle, and you will randomize only the females. And then you will put them into that group. It can be done for age, can be done for sex, can be done for any other variable that you're interested in. So once you do that, you eliminated that variable as a risk factor. So you can no longer go and measure that variable anymore. What you have is that you have cases and controls, or you have intervention and control groups that are really similar in the distribution of that variable, because you've identified that that variable is a known confounder. A typical example is cigarette smoking and maybe how it affects the dentition and the kind of maybe cancers or stuff that it causes. And if you have that, and you also know that these people are male and female, you know that males are bigger smokers than females. Then you may also know that males have a higher predilection for oral carcinoma compared to females. So what you want to do is you want to make sure that you have an equal number of males and females in the study while you are doing your study. All right, blinding. Now, blinding talks about concealment of group allocation, and it's there to prevent bias. So if you have the process of randomization may or may not happen, matching is happening, but the important thing is that allocation to one group or the other is not, there are certain people that are not aware. So I know there's this talk about single blinding, double blinding, some people will say triple blinding, but I like to understand it as in the line of who are you concealing information from? So you can conceal information from participants, the so-called single blinding, if that's all. So they don't know, as they are picking the numbers to be randomized into one group or the other, they don't know which group is intervention, which group is control. And the reason for that is that you do not want them changing their reports about the effect of the intervention. Once they know that this intervention, I'm the one getting intervention, somebody who will start feeling well. There's that psychological effect. Or the person knows I'm not getting intervention, it becomes the person is the sickest person in the room when you're talking to the person. So you want to blind. And the way to, but you know that it's not always possible for participants not to know what they are getting. With drugs, yes, especially if you're coming up, you can come up with a placebo, which just looks like the drug on facial recognition, but it's inert. It doesn't have the active ingredients or chemicals of that drug that your testing has. But what about surgical interventions? How do you blind? It may be a bit difficult, and some creativity may be needed to know how you may actually attempt at some blinding. What about when the research assistant, and when you talk about researchers, we're actually referring to primarily the people that are collecting information from these patients, from these study participants. So if we're supposed to collect maybe monthly information after these drugs have been given out, those people shouldn't know, ideally, who is in intervention and who is in the control group, because it may influence their measurement of effect. So they shouldn't know, ideally. So research assistants may not know, but the overall managing team of researchers may know. But the people in day-to-day interactions will probably not know. Now, practitioners, people who are providing treatment, it's feasible that you can also blind them. So they are coming and they are providing the same treatment to everybody. They are checking on them. They are doing their rounds and all of that. They don't know who is intervention, who is control. So there's no special attention or reduced attention. And then very importantly, you can get to a point where the data analysts It's coded group 1, group 2. They don't know whether group 1 is intervention or group 2 is control. So those people who are usually going to be the adjudicators of effects, the ones who are going to say, there's an effect or there's no effect, they don't know. They don't know what is happening, whether this is intervention or control group. So there is no bias, and by that way, you have improved the validity of your findings. We're coming to an end. I thought to add regression modeling, because with randomization, matching, and blinding, to a large extent, you are talking about during your design stage, during recruitment into your sample, during the data collection, and so on and so forth. It's possible that you didn't get it 100% right at that point. And so you may need to do something during data analysis. So you have statistical methods that help to improve the validity of your study by identifying and controlling for confounders and minimizing the activity of bias in your data analysis. And the most famous tool for doing that is by regression modeling, either the linear regression in which your outcome variable is a continuous variable, or your logistic regression in which your outcome variable is dichotomous, or the multinomial regression in which your outcome variable is multicotomous or categorical, more than 2 categories. And so by doing that, you have a regression model in which you bring in all possible known and unknown confounding variables. And if there's a relationship that is shown in when you calculate at the first level, your odds ratio, your crude odds ratio, you will see okay, there's a greater odds with this variable, there's greater odds with this variable, there's greater odds with this variable, when you do your straightforward associations. But by the time you put all these variables that have been shown to have one association, one relationship with the other, into your regression model to get your adjusted odds ratios, you will now see that the moderation of the confounding variables has come in, and you will know which variable truly has a relationship and which does not. So a variable that may have had a significant relationship in the crude odds ratio estimation, by the time you adjust it, that variable may have a higher, a lower, or no relationship whatsoever. And that is also a helpful way. In conclusion, randomization, matching, and blinding are research design and statistical methods. They help to improve the validity and reliability of analytical and experimental research through identification, control of bias, and confounding. Now, they are subject to procedures, and they all have challenges. Sometimes they are not all very easy. But it is important that we strive, especially when we are carrying out interventional study designs, we strive to implement one or more of these tools for us to be able to improve the validity of our work and make sure that we are producing quality, high impact research. Thank you so much for the time. Apologies that I shot a bit over the time because of the going in and out of connection. Thank you very much. I'll be happy to take questions when that time comes. Thank you so much, everyone.